I'm called Professor Eugene Chinyanda. I head the mental health section at the Medical Research Council unit in Uganda. And I started working with this institution about 12 years ago, and I've mainly been doing research into the mental health aspects of HIV. So we have done a number of epidemiological studies, and we have observed that there's a considerable burden. Between 15 to about 30% of patients with HIV have at least one of the psychiatric problems, most commonly depression. So as a consequence of that, we decided that now we need to address this depression in the HIV care. Right now, most of the HIV care in African hospitals, including Uganda, does not provide the management for depression or other mental health problems. So we feel that there's a need to integrate the management of mental health problems in order to improve the quality of life of these patients that have HIV. Even through our studies that we have done, we found that actually if you don't address depression, the patients will not adhere very well with the medications. The patients may practice risky sexual behaviors. And also depression in studies done in the West has been shown to be associated with faster HIV disease progression, including earlier death. So it's important that we do not neglect the management of depression and other mental health problems among patients with HIV. So there's a need to actually integrate the management of these disorders in the care of patients with HIV.
I'm called Dr. Nasanga Ruth. I'm the District Health Officer from Mpigi District. Medical Research Council identified Mpigi District to participate in the management of depression among the HIV positive clients. They've been doing a small research in Mpigi, and they were trying to answer the question, is it possible to improve management of HIV plus depression using the available resources and within the available structures? That has been the research question. So they identified us to participate before they go in for a much larger study.
Nakaungu aneti okusinga nnima n'okusuubula ku buntu obutonotono kale mabegako nga si era sidda nnyo naye kale nga Desemba oyo ow'omwaka oguwedde yali aggwako awo omwaka ogwo gwali guggwako ne nfiirwa bba wange n'afa naye ekyampisa bubi nnyo nnyo kubanga abaana bato era natunuulira embeera nendaba nga kwegamba nga asigadde mu bbanga. Jjukira era ndi ku ddagala obusobozi olwo ndaba nga ate sikyayina kwegamba nafuna ebirowoozo bingi nnyo. Natandika okubeera mu mbeera gye sitegeera nga n'otulo tumbula seebaka mu wiiki n'oyeebakayo olunaku lumu ate n'olunaku olumu lwe weebase nga oyinza okuweebaka ssaawa 3 ssaawa 8 n'obeera ng'otunula paka ku makya ng'okulya ekyo kyafuuka kizibu kyange gyendi kaakati nga kweganga appetite yafiira ddala nga ne bwe ndya emmere mpuliranga etagenda olwo ne bwe natandikanga okumira eddagala nga mpuliranga n'empeka etakyayita mu bulago kweganga ne mpisibwa bubi nnyo ng'amaanyi nze gwe gaggwamu buli budde nga mbeeranga omulwadde nga siva mu ddwaliro buli budde banzijjako omusaayi naye nga siri muki ne baŋŋamba kyo kiki naye nga nembeera bwe ntyo mu mbeera eyo ate nga sirina nnyo nagwe ŋŋamba nti oba naamugamba nti oba bannaye naye nga mbeera bwe ntyo mu nnyumba neebakamu n'abaana bange sirina gwe ŋŋamba nti kino naye kati era twali tuzze wano ku ddwaliro kati awo omusawo ne batandika okusomesa abo waliwo omusawo Debula ne Josephine yo Debula kati ne batandika okusomesa ku eyo mbeera ya depression mu butuufu ebintu byonna nga bwe babyogera nga ndabira ddala nga nze wenkolaki mwengwa era nkukakasa mu be baayita okugenda mu musomo ogwo nze nagusookamu.
I'm called Deborah Mwangzi. Depression training had given me skills, how to handle people, how to talk with people, how you can say with the people and tell you what you feel. Every time you see that this person is sad, he has her own problem sometimes. No, there are challenges when we work with depression. Yes, he gave us chairs, tables to use, but we didn't have any room for depression.
The years I've worked here, I'd never got any person confessing, because I've been interfacing with them, I've been seeing them, I've been talking with them, but we have been doing the normal counseling. We could talk to them, and sometimes we could not give them a lot of time, real time, to identify the real issues. But during this project, this pilot, the counselors could screen, and at the end of the day they could refer clients to me who were eligible to be referred to me. And during my interaction with these clients, I found out that people have real problems, and people were attempting even to kill themselves, to call out suicide. And someone surely confessed, not one, not two. And even they could tell you how they were going to do it and everything. So it was so amazing. I was so surprised. For the years I've worked here, I never got any client. Imagine from HIV clinic who could confess. So that means even we have been losing clients, and we thought they were dying because of the condition they had. But in the long run, it was depression. And we managed, and we treated them, we gave them the therapy they needed, and at the end of the day, they improved very well.
We are fortunate that in 2016, we got funding from the Wellcome Trust Fellowship, Wellcome Trust grant, which is a senior Wellcome Trust Fellowship that was awarded to me. And this grant is helping us to design an integration model, seeing how can we use the existing structures. Because I mean, if you come to the Ministry of Health and say, I want you to hire new people, I want you to hire this, the Ministry of Health does not have the resources. So we wanted to design a model which uses the available resources that we have, the available manpower, the available structures, so that we can see how we can integrate depression into this. So the Wellcome Trust gave us the funding for this, and the first phase, which we have been conducting in MPG, was to develop this model. And now the next phase is going to be a clinical trial, whereby we're going to subject this model to a trial. I mean, this is a rigorous way of assessing whether this model actually does address depression or not.
Depression among people with HIV is a problem that goes unnoticed, unidentified, and untreatable. So, among people with HIV, about 10 to 30% have a depression, but they suffer unknowingly, and many of them commit suicide. So this time we purpose to establish how depression affects people with HIV/AIDS, and also look at what might be the ideal treatment models that are feasible, sustainable, that could be delivered with fidelity, and that are acceptable by the local population. So we had to look at screening, establishing a modality of screening, which is in line with the Ministry of Health operational guidelines about integrating mental health in HIV care, integrating depression management in HIV care. So we had to identify models that have worked elsewhere, adapt them to the HIV care situation, and be able to use behavior activation, what we refer to as a health activity program, which is a psychological model to help people be able to overcome depression.
This has been one of the very interesting projects, providing opportunities to learn, opportunities to think about things that were not thought about before, things that we knew but we did not know much about. Yeah, we knew depression was there, and we thought we were actually doing our best. We thought we were doing much, but the project has actually provided an opportunity to know more about it, to actually identify the gaps, but also demonstrating that actually we can manage it. We can do better than we're doing, especially integration. One of the things actually we didn't know was the behavior activation or the psychotherapy. That at that level, you know, a non-mental health specialist, a non-psychiatric nurse, a non-psychiatrist, a non-psychiatric clinic officer can actually be empowered, yeah, and use that psychotherapy, you know, to help a patient get out of depression without necessarily administering antidepressants or administering tablets. Yeah, so to us that is phenomenal, and it is something we think we can develop and then scale it up, implement it to scale more than just the pilot district.
So by the nature of our intervention project, we found that we are able to, clients were able to recognize that they have these problems. The health workers who have also been sensitized, and they're now able to screen these patients to recognize this problem.